The McKenzie method compared with manipulation for non-specific low back pain. Many chiropractors and physical therapists utilize a technique called the McKenzie method, also called mechanical diagnosis and therapy. This technique does not involve manipulation and is considered a less aggressive approach compared to manipulation. A recent Danish study published in Spine compared the management of patients with low back pain and included patients with and without leg pain. The comparison was between those managed using the McKenzie method or manipulation, in addition to giving patients an educational booklet and advice. The title of the publication is The McKenzie Method Compared with Manipulation when Used Adjunctive to Information and Advice in Low Back Pain Patients Presenting with Centralization or Peripheralization, a randomized controlled trial. For those unfamiliar with this approach, I'll review some of the basic concepts prior to discussing the design and results of this study. The approach was stumbled upon by Robin McKenzie, a physiotherapist in 1959, through observation of patients and the response to various held or repeated positions. This led to a categorization into 3 syndromes of low back and eventually also neck pain: the postural syndrome, the dysfunction syndrome, and the derangement syndrome. The distinction is based on the observation that the first 2 syndromes present differently due to involve strained or shortened soft tissue, whereas the derangement syndrome might represent disc and or nerve root pathology. Although McKenzie was quick to state that there was not an intent to diagnose disc herniation, stenosis, or facet syndrome, his subcategorization does make some attempts at association. Let's review the basics of the McKenzie method so you'll be acquainted with each major category and some of the unique terminology associated with this approach. With the postural syndrome, patients are generally young, usually less than 30 years of age. They're often sedentary and not very active or fit. Pain occurs with prolonged static posture that's either poor posture or sustained end-range posture. The pain is described as midline pain with no radiation. The postural syndrome presentation is never induced by movement, never referred or radiating down the leg, and never constant. Importantly, movement is not limited or affected. With the dysfunction syndrome, the patient is usually older than 30 years of age. There are 2 proposed causes: postural syndrome over decades and scar tissue formation from prior injury. The pain is of an insidious onset and is local, often midline pain. Pain is felt at end range, but not during movement. There's no radiating or referred pain. For the dysfunction syndrome, there is a limitation of movement due to end-range pain and restriction. Characteristically, compared to the derangement syndrome, the pain does not last long. Before we move to the last syndrome, derangement, it's important to define several terms. First, centralization and peripheralization. These terms are used to describe what happens to pain in relationship to the back and leg in response to certain testing maneuvers. If the pain radiates away from the back toward and down the leg, the pain is said to peripheralize. If instead the pain moves away and up the leg more to the back, the pain is said to centralize. Again, these are changes in pain induced by specific movement testing approaches. Another term used in this study is reducible disc. In essence, this refers to centralization. So why use the term reducible disc? It turns out that although not initially intended to diagnose pathology, the McKenzie categories eventually evolved into several subcategories of derangement related to disc pathology. We'll address those in a moment. For the derangement syndrome, patients are generally between the ages of 20 to 55. The onset is often sudden. The pain may be local or radiating. Unlike the other 2 syndromes, the pain in the derangement syndrome is constant. Movement will either peripheralize or centralize the pain. There are 7 subcategories of derangement which reflect both different patient presentations and also theoretically different possible matched disc pathologies. Let's summarize. Categories 1 through 4 do not have symptoms below the knee, whereas 5 and 6 do. Categories 1 through 6 represent possible posterior or posterolateral disc pathology. Category 7 represents anterior pathology and is more often responsive to flexion movement. The categories are arranged as couplets: 1 and 2, 3 and 4, and 5 and 6. The odd-numbered categories are the distinguishing ones, such as 1 with central or symmetrical pain not below the knee, 3 representing unilateral pain not below the knee, and 5 unilateral pain below the knee. The even-numbered categories represent associated ontalgias matched with the lesser odd-number couplet. For example, 2 is coupled with 1 but with a kyphosis. 4 is coupled with 3 but with a scoliosis, as is 6 with 5. And 7 represents orlordotic antalgia. Let's review and summarize the differences between dysfunction and derangement syndrome in relationship to pain and movement. For dysfunction syndrome, pain is at end range only, disappears when the end range position is released, and the pain does not last long. Importantly, repetition of movement does not make the pain progressively worse or peripheralize it. For derangement, repeated movement or held patterns either centralizes or peripheralizes the pain. The position that centralizes may not entirely cause pain to be in the low back only, but will be less distal. When pain is centralized by a specific movement, that movement is often referred to as a directional preference. There's generally a sequence of testing patients when examining with the McKenzie method. The sequence is flexion, extension, and side gliding with standing, and flexion and extension with lying. Each of these is tested as a held and a repeated pattern to determine the effect on pain. So who were the patients? The inclusion criteria were patients between the ages of 18 and 60, patients with low back pain with or without leg pain for more than 6 weeks. They had to be able to speak and understand the Danish language. They had to present with clinical signs of disc-related symptoms and had to fulfill the clinical criteria for centralization or peripheralization of symptoms, with or without signs of nerve root involvement. The exclusion criteria were no symptoms on the day of inclusion, demonstrating positive non-organic signs, if serious pathology was suspected, an application for disability pension pending litigation, pregnancy, comorbidity, recent back surgery, language problems, or problems with communication, including abuse of drugs or alcohol. Patients were randomized into 2 groups with no control group. In the McKenzie group, treatment was planned individually following the physical therapist's pre-treatment physical assessment. Manual vertebral mobilization techniques, including high-velocity thrust, were not allowed. An educational booklet describing self-care or a lumbar roll for correction of seated posture was given. For the manipulation group, all types of manual techniques including vertebral mobilization, high-velocity thrust, and myofascial trigger point massage were used. General mobilizing exercises such as self-manipulation, alternating lumbar flexion extension movements, and stretching were allowed, but no specific exercises in the directional preference were allowed. Also, an inclined wedged pillow for correction of seated posture was available to patients. The primary outcome measures were the number of patients with treatment success using the Rowland-Morris questionnaire, and secondary outcome measures were reduction in disability and pain, global perceived effect, general health, mental health, lost work time, and medical care utilization. Specifically, success was indicated with an absolute score reduction of 5 or greater points on the Rowland-Morris, or a 30% reduction on the Rowland-Morris score. The results are interesting. The percentage of patients who were judged as successful was 71% for the McKenzie method versus 59% for manipulation. The McKenzie treatment method was judged superior to manipulation using the number of patients who reported success following treatment as the comparison. Also, the McKenzie group showed more improvement in their level of disability compared to the manipulation group. 2-month and 12-month follow-up was similar, with a mean difference of 1.5. Not stellar, but statistically better. So the obvious question after seeing these statistics is this a clinically significant difference recognized by patients? The researchers concede that the differences are statistically significant but unlikely to represent any clinically significant difference. Let's look a little deeper at the patients to see if differences might have affected the results. There were more female patients in the McKenzie group. The number of patients on sick leave was greater in the manipulation group, and the number of patients with symptoms below the knee was greater in the manipulation group. So we might conclude that at baseline, the patients assigned to the manipulation group may have had more severe or serious problems. Let's look at some other differences. The dropout rate was highest in the manipulation group, with more patients dropping out due to lack of effect during treatment. More patients in the manipulation group were sent for surgical consultation, which makes some sense given the observation that more had below-the-knee complaints. More patients had practical obstacles to continuing treatment, such as work hours, in the manipulation group. Here's a very interesting finding not discussed in the study at one-year follow-up. Of the original patients on sick leave, only 13% of patients in the manipulation group were still on sick leave compared to 21% of patients in the McKenzie group who were still on sick leave. The researchers did some post-hoc or after-study data analysis that's interesting. 70% of the patients who were centralized patients had success in the McKenzie group. So out of 151 patients who centralized in the McKenzie group, 105 had success. Only 59% of the centralizing patients had success in the manipulation group, so that out of 156 centralizers in the manipulation group, only 92 had success. Now, let's look at the peripheralizers. 67% of the peripheralizing patients had success in the McKenzie group, that's 16 out of 24. 37% of the peripheralizing patients had success in the manipulation group, that's 7 out of 19. So can you trust the results and conclusions of this study? Well, the size of the study is adequate. However, there is no control group and the dropout rates were rather high. Also, the distinction between who was manipulated and mobilized and to what degree trigger point massage influenced results is unclear. What about other studies? The literature is mixed. Certainly for the agreement among examiners, the inter-examiner reliability for the McKenzie analysis has good results with a kappa value of 0.64. For diagnostic testing validity, discography was used. The construct validity using a positive discogram as a reference standard for disc pathology produced a likelihood ratio of 6.9. For treatment effect, a recent randomized controlled trial comparing the McKenzie method to first-line care for acute low back pain demonstrated no advantage to the use of the McKenzie method, but again, this was for acute low back pain, not subacute or chronic low back pain as in this study. Previous studies that compared the effect of the McKenzie method versus manipulation in mixed populations of patients with acute and subacute symptoms of low back pain found no difference. 3 randomized studies have tested the effects of the McKenzie method versus spinal manipulation in a subgroup of patients with predominantly subacute and acute low back pain and indicated improvement with end range motion during physical exam. So, should you use the McKenzie approach or manipulation? For low back pain patients who have had symptoms for at least 6 weeks and who, upon exam, centralize or peripheralize, either McKenzie or manipulation seems fairly equal in effect. There may be some advantage to the McKenzie approach for those patients who peripheralize compared to their response to manipulation based on this study. Although the McKenzie group did slightly better compared to the manipulation group on the primary outcome of the Rowland-Morris questionnaire, at a one-year follow-up, a higher percentage of patients were on sick leave in the McKenzie group versus the manipulation group, indicating an advantage for the manipulation group in work function. It would seem that either is appropriate as a first-line approach to patients with low back pain that present with or without leg pain. If the initial first-line choice is not effective, switching to the other approach seems an appropriate second management choice. It might also seem logical to have both approaches as part of your technique repertoire for low back pain.